there are a total of 2,573,471 confirmed cases and 178,558 deaths reported to the WHO. As we can see in this map, it's updated every time by the WHO. It is technically almost everywhere. According to the situation report released by the WHO on April 18, as we can see in this epidemic curve, that the pandemic was led by the Western Pacific, primarily from China, and then the whole world followed. The impact is said to be worse in countries with delicate healthcare systems. So here are the epidemic curves from different countries. As of this moment, most countries are yet to flatten their own epidemic curves. In terms of transmission, there's not much difference in terms of sex. It is apparent that all ages are actually infected. However, there are more confirmed cases from adults compared to children. Whereas in terms of death, actually, the majority are noted among elderly male elderly male. Although it has not been studied in the context of COVID-19, here are some theories regarding this male predominance. Some actually hypothesize that aside from behavioral factors like health-seeking behavior and self-care behavior between sexes, it may be due to biological factors such as females mounting more strong immune responses due to extra X chromosome or our genetic component, and by the fact that immunity cells were found to have female hormone estrogen receptors. So these are just trivia as to how they think why males are more susceptible to COVID-19 deaths. Just a review, I'm sure a lot of us are actually familiar with this already. COVID-19 is the disease that is caused by SARS-CoV-2, just as AIDS is caused by HIV. Coronaviruses are a large family of viruses that causes a large set of manifestations from simple common colds to severe diseases. Other examples of coronaviruses actually include MERS and SARS. Symptoms of COVID-19 include the following: fever, cough, fatigue, loss of appetite, shortness of breath, and muscle pains. So the percentages here are just shown for us to realize how common it appears in our patients. The cases we're actually seeing right now are just the tip of the iceberg. Severity of manifestations has a high variety, with 80% of the cases presenting as mild to moderate. Mild as those who would have fever, cough, and then moderate who would have pneumonia. And 50% could actually present with severe, and 5% could actually present with critical cases. But it has to be emphasized that one could actually change severity along the course of the illness. For example, around 10 to 15% of the mild cases can become severe, needing hospitalization, or may lead to death, while 10 to 15% of severe cases can actually become critical. As we can see in this figure from the WHO, it takes around 5 to 6 days after the actual infection before the symptoms actually appear. It is a self-limiting condition. It means it could resolve on its own. Symptoms to recovery takes around 2 weeks for mild cases and 3 to 6 weeks for severe cases. So according to the WHO, the mortality rate as of March 2020 is around 3.4 deaths per 100 people with COVID. So it's that small. However, transmission-wise, as we could see here, we have described the reproductive number, or the R naught, as we hear a lot in the news. So it means that the R naught means actually the estimated number of people that a person with COVID can actually infect. So it's measured around 2.3. So it means that a person who is infected with COVID can actually infect 2 to 3 other people. This is actually much lower than measles, which is found to be 12 to 18, and chickenpox, it's around 5. COVID-19 or SARS-CoV-2 is actually transmitted via droplet transmission, meaning the virus is carried by small droplets that come from the nose or mouth of person with COVID-19 when he or she speaks, exhales, coughs, or sneezes. Infection can also happen when an infected person touches the surface or object that has viruses on it and then touches their eyes, nose, or mouth. There's actually no evidence of airborne transmission in the community setting if you're concerned. However, in hospital settings where there are procedures actually done on the nasopharyngeal areas or in the nose and the mouth of ill patients, it could actually become airborne. But in terms of community setting, we shouldn't be actually afraid of possible airborne transmissions. Currently, there is neither a cure nor vaccination available. Only supportive measures are done for treatment, meaning we only treat the symptoms. For example, we give paracetamol for fever or oxygen supplementation for difficulty of breathing. Since there is no available cure, the best way we can do to fight this virus is actually through prevention. The best known prevention with highest efficacy and level of evidence is actually as simple as hand washing. Washing with soap if hands are visibly soiled, or using 60% or 70% isopropyl alcohol-based hand rubs. And of course, let us take care of our hands by not using hot water and making sure that it is moisturized daily. It has not only been recent that the US CDC recommended the use of cloth masks for purposes of public safety, especially to decrease the spread during times when there are instances that are unfortunate for us not to be able to comply with physical distancing. It is important to emphasize that we should also spare surgical and N95 masks, not only because to save some for our healthcare workers, but also because it is inappropriate to use in community settings. Physical distancing and cough etiquette are also important. If one is sick, it is best to isolate for 14 days to prevent spread. Lastly, it is important for us to stay healthy by making sure our other medical conditions are well managed. For example, controlled blood pressure and blood sugar, and maintaining a healthy, balanced diet and habit of physical activity. In terms of COVID-19 and HIV, there's only a little certain information about it to date. Most of the knowledge we have right now were based on previous studies with other coronaviruses, such as SARS and MERS. But in general, patients with severe immunodeficiency, which include people living with HIV not on antiretroviral therapy, or those with low CD4 counts, usually have higher risk for complications with any infectious diseases, which emphasizes the importance of taking antiretrovirals and prophylaxis for pneumonia. There are only a few studies done, and these are mostly case reports. One study in China has noted the same clinical outcomes in PLHIV and non-PLHIV infected with COVID, meaning in terms of severity, in terms of recovery, they are the same. There's the study in Spain that has shown a variety in manifestations and co-infection with other opportunistic infections, which are hard to differentiate with COVID-19, especially in those who are in the late stage of HIV infection. Currently in my practice, I only have 2 likely COVID cases, which both presented with mild symptoms. For example, muscle pains, fever, and cough. However, my patients were not confirmed due to the limitation of kits in our country. However, amidst the dearth in our data, it is important to emphasize that comorbid conditions like diabetes and hypertension, diseases of which PLHIV has higher risks to have due to chronic infection in ART intake, are documented to be associated with severe clinical outcomes. In conclusion, Much to investigate, but one thing is for certain. It is more than it's now more than ever that it's important for us to remind everyone that they should be taking the ARTs. In terms of COVID-19 and antiretroviral therapy, this hypothesis actually came from previous experience with SARS. There was a note of decrease in incidence among patients with AIDS confined together. This prior experience led people to actually hypothesize the possible use of ARTs in COVID-19 patients. Thus far, the use of lopinavir-ritonavir has not been shown to be clinically beneficial in severe cases, with no inference, however, on mild to moderate cases. However, it is included currently in the WHO Solidarity trials alongside with a handful of clinical trials around the world as venture to find the cure. Since most of us have experienced lockdowns, partial or extreme ones, we are very well aware that COVID-19 is not the only problem we should be eliminating. In this figure, we could see other curves that we should flatten in the next few months. COVID-19 has not only put a lot of people at risk for stigma-related violence, but also mental health challenges like anxiety and depression. It has interrupted care on emergency cases like stroke, heart attack, chronic conditions like hypertension, diabetes, and global emergencies such as the HIV epidemic. The lockdowns and staying at home directives could perpetuate violence at home among already vulnerable groups like women, members of the LGBT, and people living with HIV. There were reports of abuse of power among government officials, singling out members of the LGBT to kiss one another, perform sexy dances, and other lewd acts as punishments to violations of quarantine protocols. This epidemic has exacerbated existing health disparities, secondary to discrimination based on sexuality. There are no current published studies on specific concerns of people living with HIV amidst COVID-19 and lockdown. However, in the Philippines, UNAIDS and UNDP have released the results of their survey on treatment concerns of pill HIV. To help us appraise the findings, the survey was performed primarily on young population of MSMs, around 20s to 30s, which could reflect the HIV epidemic in the Philippines. Concerns were primarily transportation, delivery, location of treatment centers, checkpoints and borders, and stocks of ARTs. There are interesting trends throughout time, like increasing numbers in needing of financial assistance, employment, and psychosocial support. On top of these are undiagnosed cases, not on ART, and are lost to follow up. Alongside with global and national measures to ensure cascades of care, communities have risen up to the challenge of ensuring provision of HIV testing and treatment services. I know we do have different experiences in our countries, but I will be primarily sharing what we do in our organization in the Philippines to make sure we continue to provide to our 6,000 pill HIV clients for treatment, 1,000 people on PrEP, and countless clients who need HIV screening. With approximately 25,000 Filipinos living with HIV unaware of their HIV status, awareness campaigns, of course, do not stop. We keep on mobilizing the community through social media campaigns like online concerts and games. For HIV screening, we have launched Self-Care, our project for self-testing. Our screening sites are open with all our staff wearing appropriate personal protective equipment, with strict triaging at the entrances, and asking our clients to do self-triaging at home prior to going to our centers. For ARV refills, as we all know, the Philippines is actually an archipelago, so it has a lot of borders and it has a lot of restrictions when it comes to geography. Our local government mandated that all people living with HIV could refill in any nearest treatment facility from their homes. Then came Google Maps guiding all our PLHIV where the nearest facility to them. Our ARV refills are now primarily done through couriers so that our patients could actually stay at home. To ensure retention, All our clients, especially those who were lost to follow-up, are being called one by one by a designated volunteer life coach to ensure safety and compliance to medication. If any patient has any medical concern, they could see their doctors through telemedicine. Lastly, consultations do not stop. These are countless, there are countless surveys to ensure the well-being and even sexual and health-seeking behaviors of our PLHIV, of those who are in the key affected population of the HIV epidemic, for us to tailor our services to the dynamism there is. In summary, it is, it is indeed a difficult and challenging time for all of us. Unprecedented, that is. All of our learnings from previous outbreaks like SARS, Ebola, have made us stronger than we think. Our personal experiences with our work in the HIV epidemic is itself an advantage. Right now, we may be physically isolated, but we're all actually connected. Amidst all the challenges, however, it has brought out heroism in all of us, from staying at home, washing our hands, and protecting ourselves, to working to provide essential services like what we do. In cases of emerging infection, the first line is actually the community, and we have a big role to play. That's all.
Thanks, Patrick. Um, does anyone have questions to Dr. Patrick? Patrick, I have some few points that would like to would like you to clarify. So earlier in the slides, you have mentioned the community setting transmission, that there are less cases of community setting transmission. Can you explain more? What do you mean by the community setting?
Okay, so when we actually talk about community transmission, um, we could actually say that we could actually assume that around more than 50% of the actual COVID cases are actually in the community and not in the hospital setting. So whatever we see on the news or in our hospital reports, it's actually the tip of the iceberg. However, if in terms of transmission, actually when we are in the community setting, it's less likely that we're going to be infected, especially if we're going to stay at home and we're going to protect ourselves and we're going to do hand washing and etc. As compared to those who are in the hospitals, we're actually in the midst of the density of the cases, of the severe cases. And actually, for example, doctors and nurses who are performing procedures on ill patients, specifically on their nasal and oral areas, wherein the secretions or wherein the the virus can actually be transmitted. In terms of exposure, they're actually exposed much more compared to us in the community. So as long as we stay at home, as long as we wash our hands and don't touch our faces, as long as we wear cloth masks outside, we're actually as much protected compared to those who are in the hospitals.
So community setting meaning people like the general population.
Yes,
Are
the general
required to
population.
stay at home. So it's not like the community level, like our community, like the LGBT or key population community. So basically, it was more
It's general public. Yeah.
general public or the general population setting where people are required to stay at home.
Yeah.
And then you mentioned earlier about triaging of symptoms. So Love Yourself has practiced several measures to make sure that the staff are safe and secure against COVID.
Yeah.
You mentioned
Yeah.
about making sure that there's a triaging of symptoms.
Yes.
Yeah.
So the triaging actually, so when it comes to prevention, it's actually an effort of both of the healthcare workers or the community workers like us, and of course our patients and and our clients. So for example, in our part, we make sure that we have personal protective equipment and in our entrances, we do triaging before we let them enter the community centers. As for the patients, we ask them to be responsible enough to ask themselves several questions. For example, if they have fever or cough, or if they have flu-like symptoms, or if they were exposed to anyone who's actually a confirmed case of COVID. And then if they pass the triaging, they could actually go to our community centers. It is to ensure the safety of the general public and of course our staff who is currently working in our centers.
So as a medical practitioner, so you're practicing that measure in Love Yourself, but what are the I think the standard measures that anyone, like any CBO, can apply? What are the basic measures that they should be observing on a CBO level?
Okay, so in terms of CBO levels, it actually depends on the extent of the services you actually provide when it comes to HIV testing and treatment. For example, if the community setting has syringes has or requires close contact with patients, it's actually a very standard operating procedure to actually at least to have personal protective equipments. Actually, regardless of our situation right now, it's actually standard operating procedures to actually to protect ourselves first and foremost. So, but the current climate actually requires us to become more stringent when it comes to personal protection. So, for example, at the CBO level, if the if the if the community workers are screening people with HIV who who could be infected with COVID should actually wear personal protective equipment, or would rather defer first the screening before allowing them to visit the centers, because it is the protection of the staff and all other people in the community centers is our priority right now. Because if it starts to spread in one area, we we might be having difficulties on continuing to provide our services. So it's actually important to really control the infection first to really make sure that we're not exposed to any possible cases.
Thanks, Patrick. So Ali has a question that he just entered into the chat box. How can we mitigate the psychological effects for the PLHIV community during this COVID-19 situation? And what are the possible methods or strategies that can be adopted to deal with the stress?
Okay, actually, that is a very relevant question. Some of my patients actually disclose to me how it's taking a toll on their mental health. In general, however, since pill HIVs are actually more at risk for mental health challenges, it's actually important for us to make them feel that there's a community that is there for them. Um, so, for example, in our community center, we release a lot of social media materials, especially that it is likely that all of the people right now are actually online since they won't have anyone to talk to. But for example, if the patients are actually in areas wherein there's no available internet, it's really important for them to talk to their to talk to talk to their friends, to their immediate family, to their neighbors. It's really important to talk to other people. And aside from that, to do other things that might interest them. For example, do their hobbies, those things that they couldn't do before the lockdowns. Something that they can help with coping with a lot of things. It's really important for them also to stay healthy, to eat a lot, because mental health is actually um, it's actually a combination of a lot of physical, social and psychological well-being of a person. So as long as we eat healthy, it's going to be fine. As long as we also provide them with emergency numbers when it comes to emergencies such as suicidal ideations or suicide attempts, it's really important for us to give them the emergency call numbers or some people that they could actually talk to when it comes to those things.
Thanks, Patrick. I'd like to add on that point. So Ali, please feel free to share some context that is relevant to your country. But so I am myself a person living with HIV, and when the pandemic started, there was really the stress and the worry about me getting COVID because there was there were information circulating that people living with HIV are more susceptible to get the virus than those who are not living with HIV. However, you know, because of those information, I kind of like sought clarification from several physicians that I know. There currently, as Patrick has mentioned, there are no studies yet conducted about the higher, whether or not people living with HIV are at higher risk of acquiring COVID. But for now, what we can provide the PLHD community is correct and accurate information about COVID and how important it is for them to be adherent to treatment, and also making sure that their viral load are suppressed. Also, as Patrick has mentioned, making sure that there's someone or a communication platform that they can call to, and also someone they can speak with. I'm not sure if that's the context that you are currently working on. Yeah. Yeah,
It's about similar to what you said in it, but the main thing I think the PLHIV community, for example, first of all, I'd like to introduce myself. I'm Ali Raza from Pakistan, and I'm also a part of a CBO with the name of a SAPES who are working for PLHIV community here. So um, there was a lots of issues. For example, even PLHF community were contacting us regarding the availability of medications. However, the government and the UNAIDS have assured that all the medications are available to them, but still, due to psychological stress or worried about this situation, they were constantly contacting that will there be available for medications for the next 2 months or 3 months. So these were the psychological issues we were trying to um, mitigate, and that's why I asked that question.
Okay. I can share some experiences here in Thailand, which which may be useful to the context that you're working with. So the clinics or the treatment providers are providing information or announcement to their clients that they can actually access ARV good for 3 months, and they're allowed to buy or get medicines for 6 months here in Thailand, for 3 to 6 months, depending on the treatment facility that they are accessing. So during the first stages of the pandemic here in Thailand, that was also the same worry, whether or not there are enough supplies for people for PLHIV to get treatment, or will the lockdown be a restriction for them to move around the city and actually access for medicine. So the CBOs have worked with the treatment facilities to ensure that, to provide that comfort or assurance to the PLHIV community that they can access medicine for a few months, for a number of months, which is not regularly done.
Enid, I just also want to add that it is now more than ever that it's really important for us to communicate with our local governments. For example, in the Philippines, the presence of community-based organizations actually present so much demand in the government to make sure of the access to antiretroviral therapy. And and what the government did to actually reassure that the stocks of the lopinavir ritonavir to be enough, since it is going to be used in clinical trials for COVID-19 patients, is that they actually released a statement that they would really ensure the stocks for all people living with HIV. And it's really reassuring for all of the patients, for all of our clients. So I guess it's really important for us to communicate to our governments, to our own local governments, to demand, and that is the main role. That is our main role actually as community-based organization representatives, to be able to generate the demand, to be able to ask whatever our clients or what our patients are asking.
I think Magdalena has something to share, but before I give the microphone to Magdalena, I think Ali, we can talk more about this later, of how we can work together so that we can, have that information ready in Pakistan. We also have several partners in Pakistan that you can reach out. But Magda, you want to share something?
Hello. Hello.
Yeah, we can hear you.
Oh, yes. Okay. So what we're doing here in Cebu City with our CBO, which is Cebu United Rainbow LGBT Sector, we suspended our testing services. So we are just coordinating with the delivery of the ARV. Wayne, you can talk more about that, because Wayne is delivering the ARV.
So what we are doing for the past 3 weeks, since PLF Share provided us some funds for the delivery of ARV, we have delivered for the 4 provinces in Region 7, which is Bohol, Siquijor, Cebu, and Negros Oriental. But starting this week, we have a challenge already, since there are strict border controls, since Cebu City, Mandaue, and Lapu-Lapu cities are chartered cities, which means they are not part of the Cebu province government or under the capital jurisdiction of the Cebu province. So these 3 cities in Cebu are strict now, starting last Tuesday. They are having strict border controls. So for example, in Lalamove or Grab or other courier services, they can't go out or go in outside or within. They can just go or deliver inside their jurisdiction or city. So there are some clients right now who are needing some help, especially in the province side. And in Region 7 also, DOH 7 has a mechanism together with the TV program through the Strider, the courier of some specimens for TB. So for example, if a client is enrolled in Cebu City, the ARV coming from Cebu City will be delivered directly to the local government unit or health service center of the LGU of the client. But there are some clients right now who are located in a far-flung area which a Strider can't go. So that's our problem right now. We cannot provide door-to-door ARV delivery to our clients.
Yeah, that's a dilemma. So I guess the situation or and the context are very different. So in Pakistan, I guess the information of the enough supplies of ARV in the Philippines, the lockdown and the limitations to movement. Also similar here in Thailand, the CBOs are closed. Most of the CBO who are providing treatment are closed, and people need to access public hospitals, but nobody wants to access public hospitals because they get discriminated. So the problem here is how to set up a network to make sure that other PLHIVs are accessing. So yeah, these are points that I think for now we can take note of. I'm not sure if June from Japan has the same context, or are there any issues about PLHIV accessing their ARVs in Japan?
Yes, and so regarding the access for ALB, so now we are patients, we usually visit the hospitals or clinics in 3 or 4 months interval, and generally, and in that case, and if the health level and so HIV is controlled, in that case, we don't need to go to hospital often. So we receive a certain amount of medicine and in one time. And so now in my case, I have a stock of 3 months for medication, but I'm so worried because if the situation will be prolonged, we cannot be out. We cannot go out, and so we are afraid. So I'm so worried. I'm not allowed to be out because I cannot access the ALB. So probably many clinics or hospitals admit to prescribe the required medicine through the internet order. So that was one way. But in Japan, the infection is at the moment rapidly increasing, especially in the urban area, big city like Tokyo, Osaka, or mega cities. The infection is widespreading at the moment. So maybe many PLHIV people in Japan are not are reluctant to go out, so they maybe they don't want to get a medication or health consultant. And I'm also personally worried about HIV testing. So in Japan, HIV testing is in charge of a public health care center. But at the moment, they are tied up with COVID-19 testing. So they cannot afford to conduct HIV testing. So, so many people, many LGBT people who suspected if I have a HIV, I want to get the HIV test, but I cannot visit the public healthcare center because they are tied up. They are very busy for conducting COVID-19 testing. So in that, yes, and in this the confused situations, how do we cope with the effective way? So one thing is how we LGBT people, PLHIV, can prevent getting COVID-19 is one thing. And the other thing is how we can promote HIV testing at the same time. Yeah.
Okay. Thank you so much, June. So I am noting down all the points coming from different countries. I will be reaching out to you after the call of what can we do together to address this. At the moment, we don't have an answer. But Magdalena has asked a question, what are the post-COVID measures in relation to the personal protective gears? So I'd like to share some thoughts that we kind of apply, that we are promoting, like here in APCOM, we are promoting to our partners in the country level, the CBOs. First and foremost, the CBOs or the organizations needs to have their safety protocol in place. So what is a safety protocol? So it's more of like so if you have a community-based organization, you have your human resources manual, your operations manual, your finance manual. So you also, the COVID-19 safety protocol is a new guidance that APCOM has developed for the organization itself to promote and ensure that the organization's staff and resources are protected against the spread of the possible spread of the virus. So it is very important to to put these protocols in place, especially in the organization, so the staff are guided on what needs to be done or what are the processes that involves in ensuring that in the work that we do, we are still feeling safe and secure against the COVID-19. So during Patrick's presentation earlier, he mentioned about different personal protective equipment such as facial masks, alcohol or ethyl alcohol, hand sanitizers, and making sure that the hands are washed. But we have learned in the organization that if these protocols are put in place within the organization, it is much easier for the organization to actually ask for support from different funders because this affects the work that we do. So these are the examples that we did here in APCOM. So because of the government lockdowns, there are flexible work arrangements, there are reduced number of working hours, there are flexible reporting arrangements to the donors. But the first 3 points that I have presented are more on a programmatic level, which means that these are more on how the organization reports itself or reports the performance of a particular program to the funder or donor, because there are donors or funders who are kind of monitoring how we are delivering or performing the work that we have committed to do. But the fourth point, which is more of like the requirement of PPE for every staff, is a more specific recommendation that the safety protocol should include as a requirement for the staff in performing the work or in delivering the services. So, for example, we are supporting some community-based organizations to purchase some facial masks or hand sanitizers so that their staff are feeling safe, or they can use these PPEs while delivering services. The Global Fund, I think this is more applicable to the Philippines and Pakistan. So the Global Fund and PEPFAR have released an information about the flexibility of the grant, of how the national grant can use 5% of the total grants to purchase PPEs and COVID-19 testing kits. And I think for the community-based organizations, especially those who are exposed to COVID-19, you are able to access, that's an opportunity for you to access, what do you call that? To access. So I'm not sure about PEPFAR, but because PEPFAR in different countries have different implementing partners. But I guess, for example, for Pakistan, you're covered under PEPFAR and you're also covered under the Global Fund. But it is good to make sure that the community-based organizations, such as your organizations, are able to request for PPEs for you to continue the work that you do. So do we have alternative for alcohol since there's shortage of alcohol supply in Cebu and the Philippines? I think we, so there are conversations happening right now in the chat room, but the World Health Organization standard that we're currently adapting is making available hand sanitizer dispensers or alcohols, like which Patrick has presented earlier, 70% ethyl alcohol, making sure that hands are washed. And in cases of travel, I'm not particularly sure if this applies to the case of curls or the organization of Ali, because you need to travel anyway and you need to go out to ensure that the services are delivered. But in the event of travels and other essential protection that you need, you have to communicate that with your partners or with your donors. But this needs to be, what we have learned in APCOM is that these requirements for staff protection needs to be in place as an organizational safety protocol. Like, it is your evidence that you are making the safety and the health of the staff as your utmost priority. And in order for the organization and for the staff to actually perform the roles, you need to have or you need to secure supplies of PPEs. And also briefing your partners about, you know, the spread of the COVID. So these are more of like the organizational standards that we try to implement here in APCOM, and also trying to share with our partners at the country level, making sure that you have your own organizational protocol so that your staff are guided and your partners are also informed of what are the measures that you are taking in place so that you are protected against the COVID infection, and what can the funders actually do to support you, because you already have your requirements, standard of requirements for your organization. You can actually ask for support on how to implement these requirements at the organizational level, because we have to protect ourselves. Like, I'm pretty much sure that country-based or country-level community-based organizations who are delivering services for key populations are also the frontliners, and you also need protective equipment to protect yourself. So there are information useful in the group chat. Thank you, Patrick and Stefano, for that. So one experience that I can share from our partner I'm not sure if it's in Sri Lanka or in Pakistan, but they're also running out of sanitizers and alcohol, and there are private corporations who are selling alcohol but with higher prices, and the CBOs are having challenges of how to provide or how to purchase sanitizers because the sanitizers are being sold on a higher price. So June has shared something. So in Japan, they use
so we cannot. It is impossible for us to get alcohol for sanitizer disinfection, and so for replacement, and the government announced in a limited situation we can use a very high alcohol contained drink like a vodka or other drinks which is the contained amount is over 80 or 90%. If we can get such kind of alcohol drink, just no problem to use for this infection. So this is a countermeasure. At the moment.
Okay, thanks, Jun. So we are running out of time. Thank you for all the information that you have shared. And these points are really valid, and I think there needs to be something needs to be done at the country level. I will reach out. I will share the presentations to everyone who has attended the call, including Siddiq. So I will share the presentations and the PowerPoints and also some of the main points that was raised during the call. And I will reach out separately to Pakistan, to Philippines, and to Japan, to June, on what we can possibly do, if at all, so that we can address this problem as immediately as possible. So if you have any more points or questions that you want to raise, I have provided my email address in the chat box. And if so, I have all your email addresses because you have registered I got your email addresses from the registration. So I will communicate and keep in touch with you guys in the next days to come. Because right now, what I think the most important thing is how to make sure that there is access to ARV for people living with HIV, especially those who are not currently reached by the programs. So thank you very much, everyone. And I hope you learned something, but I did learn a lot today. And there are new issues and new trends that currently are being faced at the country level, which needs to be addressed really soon. Yeah, let's see what we can do, but I'm not promising anything. Okay, guys, thank you very much, and thank you for your time. I'll keep in touch.
Thank you.
Thank you.
Thank you so much.